the overall spending's about the same, but they have much better outcomes. So, you know, if you were at Goldman Sachs or some kind of investment guy and you said, well, you can invest in this country and you're going to have these outcomes, or invest the same amount of money in this other country and have the worst outcomes, what should we be doing and what should our investment strategy? And I think that the data is pretty clear on that. So how are the children doing? Well, mortality rates for kids continue to decrease. Morbidity is decreasing for many medical conditions, but disparities in health outcome are increasing because there's growing social inequality in the United States. There's emergence of a lot of new morbidities and concerns, including obesity, ADHD, and mental health, and these things tend to travel together. They probably have similar sort of genesis in certain ways. And then the patterns of exposure and risk are changing, so that we have families that are squeezed, hurried children, toxic environments that kids are growing up in. And we're recognized, I think, very clearly the change that we're seeing with the obesity epidemic that's going on. But one of the things that we are not seeing or not paying enough attention to is that we have this other epidemic that's starting. I actually thought I had a slide in here, but and that is of adolescent mental health problems. If you look at the cumulative prevalence of mental health problems in our society, it's this huge S curve, and it basically happens from 10 to 25 years of age that everybody's developing mental health problems. And there's an incredible increase. So my prediction is that mental health is the next obesity. It's the next thing that we're not. And it's again, I'm going to be giving a talk here, I guess, on Friday about this, but it's just like the obesity epidemic was a mismatch between our Paleolithic metabolism and our modern, environment. I think the mental health problems have to do with our Paleolithic, mental development schemes, or maybe a little bit more recent, and what we're actually doing to children's lives or adolescents' lives. So we have this changing pattern of childhood morbidity, increased chronic health problems, and it's not hemophilia, cancer, congenital heart disease, it's all mental health and developmental issues and growing numbers of comorbidities. This is from some work that Paul Newacek and I did using the National Health Interview Survey, and it's looking at kids with disabilities in the United States, and you see that we've increased from about 2% of kids having disabilities up to about 8% by 2008. And what we know is that the children that were disabled down here, the poster child was a little girl with braces on her legs and crutches because she hadn't had polio, and the poster child here is now a kid with autism. And we just finished a further analysis from looking at from 2000 to 2011, and the disability rates during that 10-year period has increased 17%. And what was interesting, and for the first time, and as Peter Van Dyke knows, we've been doing this work for the last 30 years looking at childhood disabilities. The first time in the most recent analysis that the biggest increase in disabilities is actually happening in kids above 400% of the poverty level, and in Asian and white kids. And I think we wrote the discussion in the paper, I think it's this hurried child issue. It's the pressure on upper income kids, actually to go to college. But it's a shift that we're seeing for the first time. It's very clear when we presented in pediatric meetings. Jim parents had got up and said, well, that can't be. It's, and I think there's reasons for it. So the number of children at risk, 46% of kids with disabilities, 12 to 16% of kids special health care needs using the MCHB definitions. The 40% of kids, though, have behavioral mental health and learning problems, and about 50 to 60% of kids are good enough. And I put the good enough up there because how many here have children? Few. Those of us who have children don't usually manage towards your children being good enough unless you have adolescents, and then most of the time they are good enough. But we're trying to make children thrive or help children thrive, but we don't know how many children are thriving, whether it's 30%, 40%, or 50%, because we don't measure thriving. And so one of the issues, one of the big challenges for us from a health measurement standpoint is how do we measure thriving? Actually, Ann Riley and I are working on a project right now to see if we can develop some measures around that, and we're working with the MCH Bureau and some others to sort of see if we can sort of put these into the new surveys. this is that other thing that I was going to show you, just showed up, and this is the cumulative mental health burden in the society, looking across the lifespan. And I think it's quite dramatic to see how much the increase happened. That 70% of mental disorders happen early on, and that recent estimates is that 30% or more of kids, adolescents, have mental health problems. So we have a situation in which children are born earlier, smaller, more fragile, and at risk if they live in adverse environments with worse physical outcomes, cognitive and emotional outcomes. They're hospitalized more obese, more asthma, more mental health problems, lower health trajectories, greater brain drain that's taking place. They carry the burden of their social status into adulthood, and it's being programmed into their biology, so their adversity from poverty is being actually embedded into how they're developing, into their endocrine system, their immune systems, and neurologic function. And we know that these differences start early. This is from the Hart-Ridgely studies looking at vocabulary development. By age 16 months, you start to see a spline and functional abilities. By 36 months of age, you have more than double the vocabulary rates in children. And this is basically a measure, it's a sensitive measure of neurodevelopment that's going on. It's not the only measure, but it's a sensitive measure. And it's basically looking at what these kids' SAT scores are going to be, these trajectories. And what is sad is that 48% of children living under 200% of the poverty level. And I use 200% of the poverty level because it is 200% of the poverty level where you start to see adversity. It's not 100% of the poverty level. Under 200% of the poverty level, people do not have the resources they need to raise their children in this country. And they can't do it on a minimum wage that we have in this country. There's all these things that are wrong. So we have all these kids that are having problems early in childhood, and by the second decade you have school failure, teen pregnancy, criminality, substance abuse and anxiety, and other mental health problems. By the third and fourth decade you have these issues, fifth and sixth decade, and on. And it just cascades through the lifespan. And it turns out that those people that are having coronary artery disease, diabetes, or renal disease are probably the same adolescents that are having mental health problems because they're sitting on the couch and not, and are depressed all through their 20s and 30s, and they're part of the disabled, mentally ill, in the working age adult. So we have this set of problems that are cascading, costing us huge amounts of money. And we have a health system that's fragmented, difficulty accessing services. That's what you learn in public health school, is all about access. That's what Cynthia's been working on for years and years, and low uneven quality of various kinds of services. The models of care we use don't match our needs or capabilities, and even when we create new models, we can't get them to be used. So we will think about healthy steps for all children, which we showed to be effective, efficient, various other things, and it's not used. And limited local responsibility, operating under enormous constraints. And I show this from the Reed-Mangione-Smith study in the New England Journal of Medicine, showing that kids in the United States were getting 46.5% of what they should be getting according to guidelines in terms of ambulatory care. And when they did the same study on adults, it was about 54%. So that the kids are getting worse care than adults in the United States, getting less than half of what they should be getting. And so what we have these ideal trajectories that we like, we have this current practice, and we have this enormous missed opportunity in our country. And I show this as missed opportunity because it's a good framing for what's going on, because the United States has always been the land of opportunity, yet for many children the opportunity is being evaporated early in their lives. So with these new challenges and new paradigms, there's new strategies for us to be thinking about, and new paradigms in systems biology and life course health development and ways of organizing our healthcare services. So you've learned a bit here, I'm sure, from Bob Lund's course and others around life course development. And we've been interested in this arc of human development for quite a while. The healthcare system is interested in it also. This is just from an ad from Blue Shield of California saying, hey, these things are connected. We're connecting the dots through you. And what we've learned is that over the last 100 years or so, that the lifespan is increased, the health span is increased, and performance. So this trajectory, this health trajectory of the population has actually changed. Performance span has increased in terms of the IQ of the population has gone up by about 15 points over the last 100 years. You wouldn't know it by opening the paper, but Our health span up until recently was increasing, and it's actually probably starting to fall back because of the obesity and because of the mental health problems that we're creating. And what we've seen from the Healthy People 2020 report, for the first time, we have this life course built in. I was on the Healthy People 2010 working group, and on the work with Dr. Satcher on Healthy People 2000. I don't know, it was one of them. I kept trying to push life course, just like I used to go into Peter Van Dyke's office every year, and sort of life course, got tired of seeing me coming in the door. And so finally in 2010, they or 2020, they added life course to this sort of ecological model of multiple social determinants, but trying to think about it in this way. And what we've seen in terms of the publication is that we hit a tipping point at about 1998, 99 of life course studies, so that we've seen this dramatic increase in the number of papers being published around life course health issues. And what we've seen also happen is this intellectual sort of migration and change. So we've seen the life course sociologists that looked at the social context of individuals and age and cohort kinds of and historical effects, all like Glenn Elder, and the lifespan human development books in psychology looking at adaptivity, plasticity, and resilience, and people like Richard Lerner and others in the lifespan human development world. And they started to link their research together around linked lives, pathways, and trajectories back in the 1980s and 90s. And then what we saw is this was all shoved through a health prism when David Barker and others started to look at chronic disease epidemiology and show that there were a lot of things happening early on in people's lives that were leading to things that happen later, and especially all the chronic disease and adversity early on, and heart disease, diabetes, hypertension, various other diseases. And then you have all the DOAD work on epigenetics and the early childhood origins of adult disease, looking at the actual mechanisms taking place. So this health prism, combined with life course sociology and lifespan human development, ended up with this kind of more MCH-focused life course health development, where we talk about developmental pathways, sensitive and critical periods, about developmental plasticity, transitions and turning points in children's lives, like when they go to preschool or go to kindergarten, and the kinds of stress and things they go through, cumulative and pathway and programming effects that take place in terms of mechanisms, and the emergent aspects of health trajectories. So, and we have this sort of basic model that is developed out of this, which is that you can go into a high trajectory or low trajectory, and we know risk factors push down on those trajectories and protective factors push up on the trajectory. If you go into a low trajectory, you become symptomatic at age 60 because you're living a life of adversity with not enough support. You have obesity and heart disease and mental health problems early on. You go on a higher trajectory, and you don't start to fall apart until you're 80 or so. And that costs us a lot of money, okay? That's where all the healthcare costs are happening. So we used some of this in the Children's Health Nation's Wealth Report in 2004, where we started to incorporate some of this life course thinking into the definition of children's health. And children's health is the extent to which individuals, children, or groups of children are able or enabled to develop or realize their potential, satisfy their needs, develop the capacities that allow them to interact successfully with their biological and physical environments. This definition was very hard fought. There was a woman here from Hopkins, I think some of you might know, named Barbara Starfield, who was also on the committee. And she and I wrote the chapter, wrote this definition together. And for any of you who know Barbara, she had a very tenacious intellect and mind. So forging anything, towards consensus was always an interesting and wonderful task. You always learned a lot through that. Out of that came this notion that there were multiple influences interacting kind of kaleidoscopically, but understanding that across the lifespan, the distribution of influences changes. So the importance of family factors to kids are much more important. As individual behaviors take over, the family becomes less important. So there's different weighting of factors across the lifespan. what we've started to understand also is that if we look at children who have delayed, or disordered or trajectories to 10 or 12% versus the 30 or 40% of kids that are at risk, they have more poverty, lack of health services, more toxic stress. Kids that go into higher trajectories basically have more of these protective things. And we know that this life course orientation is important also for thinking about obesity and the genetic and also cumulative risk that happens. And we start to think differently about what are the factors in different time periods and start to manage differently. And we were, which is like kind of all about, the research agenda around health disparities, which is solely lacking in a life course perspective. You pick up health affairs and the research, the health affairs issue on health disparities, it's all on adult health disparities as if they burst forth fully formed in 40-year-olds, and without missing the case that, all these things have these longer gestations. I show this because this is a systems map looking at obesity and looking at all the factors that influence obesity. The reason I show this is not to be cute, but it's to make a point about complexity. We're not dealing with simple problems with simple models. And this obesity map, systems map, tries to take into account all the things in physical activity and in terms of food consumption and food production and social psychology and all the factors. So each of these problems, when we're talking about obesity or child development or any of them, are incredibly complex in a complex, interdependent, globalized world. For us to think that we can solve them through simple models and simple sets of regression equations that are actually telling us the truth, I think is a big, that we need to readjust our perceptions a bit. And so we have these different ways of thinking about the world, either simple models, complicated models, complex or chaotic models. And a simple model is a mechanical pump or giving an immunization. A complicated model is like building an airplane or taking care of many chronic diseases. But human development, community development, health development are all complex issues. And we're not going to talk about wildfire, but there are chaotic, but a lot of what we do in the health system verges on the edge of chaos most of the time. And we build simple systems, we design and construct, and we grow and develop more complex systems. And we oftentimes have to simplify things, but if we avoid the complexity and don't deal with actually or don't address things at the level that they need to be addressed, we don't really understand them. So the characteristics of complex systems have to do with they having common behaviors, they work at a number of levels, they have many components, and they manifest certain emergent qualities that come out of the way in which things interact with each other. And importance of that is that as our evolution of health development or understanding what produces health, we've gone through a series of eras or idea phases. So we started with Mendelian genetics and germ theory and medical anatomic frameworks. So we cut people up and see that there was a tumor there. So we said, oh, that must be causing what's going on. So it was direct observation. They came up with our biomedical model. And in fact, this is the center of where all this started. The entire U.S. medical system, sort of is Hopkins based. I mean, people at Harvard wouldn't want to hear you say that, but for all intents and purposes, this is the place which prototyped our model, our biomedical model. But it's a simple mechanistic and linear model. And as we did more studies, and especially in public health, social epidemiology became from the Framingham study, Alameda County studies that showed us that there were multiple risk factors happening over a longer time period. And all the behavioral kinds of research around smoking and eating and other things changed our model to a biopsychosocial model. And the biopsychosocial model is more hierarchical, dynamic, systems-oriented, and dealing with multiple determinants. And our current rush to think about the social determinants of health is all about biopsychosocial. It's all about how do we really focus on the social determinants. But what's happened is because of lifespan human development psychology and life course sociology, and now all the life course development work and neurodevelopment and life course disease epidemiology and the national cohort studies from most of the other countries and the epigenetic research, we now have this new model of life course health development. It's different. And it's about complex system interactions. So it's a relational model that's based on dynamic developmental emergent properties of health. So it's a very different way of thinking about it. And interestingly, on the biological basic science side, what you've seen is a similar evolution. So we've gone from Darwinian evolution and Mendelian genetics and population genetics that led to the neo-Darwinist synthesis, which was what I was taught in medical school, many of you were taught, which was a one gene, one protein, one phenotype kind of orientation. And what has happened in systems biology, genomics, and biocomplexity is you now have this post-genomic synthesis in which everything is being thought about in terms of interacting gene networks, different time horizons, different time frames. It's all about biocomplexity. And these two things are coming together because of the epigenetics and DOAD and complex system science towards a new emergent health development model. And this is going to be the model moving forward. There's a paper I wrote recently that sort of lays all this stuff out. It's in the MCH journal, but it just came out on Life Course Past, Present, Future that lays this model out. So what we know, and this is some work that I've been doing with Chris Forrest, who many of you know, about what are the principles of life course development. So we know that health is an emergent property of all living systems, that health develops continuously over the lifespan, that health development is complex and non-linear process that results from person-environmental interactions that are multidimensional, multidirectional, multi-level. That health development is highly sensitive to the timing and social structuring of exposures, that evolution enables and constrains health development pathways and plasticity. So the evolutionary effects are really, really important. We sort of don't pay enough attention to those. I mean, that's the whole obesity, Paleolithic diet, so optimal health development promotes not only survival, but enhances thriving and protects against disease. And the cadence of human health development results from synchronized timing of molecular, physiological, cultural, and evolutionary processes. This is really, really, really important and really not well understood. Every single cell in your body has a time clock in it, has a set of genes that are timed to things. And all of us live on a planet that happens to go around another planet every day, and we have these light, dark cycles and stuff. We're all tied into these time horizons that are built into our biology and how we function. And there's so much of what happens around health that has to do with time sequences getting out of sync with each other. And we're just starting to understand this from the chronobiology standpoint. So these principles of life course health development were shown here. Chris and I put this together because we didn't want to just list them, because they're actually, it's a constellation or a network, and we have here some new principles because we're not sure what, this is still, it's a complex system learning its way forward. We're still learning what we're building theory right now and needing to test it. And so how does this manifest? Well, we have health trajectories. Well, these are these trajectory I showed you earlier, but this is the brain and how it develops. But here's how, not just the structure of the brain develops in terms of its weight and development, but this is looking at, functional synaptic density and glucose metabolism and how this changes across time frame. So you're looking at days after conception, but this is around 15, 16 years here. And we know that this stuff plays forward, so adverse events in early childhood and adult depression. This is from the Folletti ACEs studies. ACEs is all the hot thing right now because people are into pediatric trauma care, so trauma now is about emotional trauma, so that's like the hot topic. We used to call it psychosocial issues, but it's now ACEs. Because I think that's cooler than, it's like Ace Ventura or Ace, Ace something, or Ace in them. So there's more focus on ACEs right now. This is looking at ACEs and heart disease. So you're looking at, the kind of stuff that plays through a child's life. But what's more important is we're understanding the pathways through the DOAD research, so that how the epigenome is affected by toxic stress and how the endophenotype changes. not the phenotype of health, but the endophenotype. And what the endophenotype is how toxic stress is affecting the midbrain and leading to changes in affiliation and attachment behavior, or the prefrontal cortex in terms of the relationship to executive function, impulsivity, or the HPA axis, or all three. And when we start to think about something like obesity in someone who has impulse control when it's stressfully eating, how much of the obesity epidemic is due to toxic stress, or why is obesity and ADHD traveling together? Well, gosh, turns out that toxic stress both affects leptin and also affects, impulse control. So, the reason, if we start to look at the developmental origins of some of these things, why these things are happening. So you have to see the phenotypes developing out of these endophenotypes, and we understand the pathways. And we're starting to understand if we're going to take care of these things, we have to have multi-sector, multi-level strategies of working. So they have to work at the individual, the family, the community, schools, health. This has to be an integrated ecological approach over time. And I show this because it's one of my favorite slides, and if you look it up on the Foresight reports, these come out of the UK. It's a project that, Foresight is a process the UK set in place to basically take on huge projects, huge complicated issues. And so they've done Foresight reports. This one was on the loss of mental capacity in the population. They wanted to understand why were people losing mental capacity. And they were dealing with the Alzheimer's epidemic like we are here. And they're sort of saying, if we can shift the curve 5 years, we save gazillions of dollars and lots of heartache and suffering. So how do we do it? And they've done Foresight reports on obesity and climate change. And what's cool about this here is this is all about environments, families, school, media, various other things, culture issues, mental capacity is looking at how the arc of mental capacity, looking at people, so you're looking at maternal diet here in relationship to fetal programming, maternal infant bonding, and you're looking at transition to school and childhood. And you're looking at how that changes in terms of the child's learning capacities and childhood trauma, evaluation of executive function, social cognition, one thing. And you start to put all this together, you start to see, well, that's why Alzheimer's is a disease of early childhood. And when we move upstream, we're talking about not just moving upstream to the social determinants, but how do we deal with the developmental determinants as well. So science is also informing policy and also how we organize our care. So the next story I'm going to tell you, now that I've told you what's wrong with the health system, what's wrong with children's health, and how we have different scientific models to better understand it. So we have a better way of understanding how we organize care if we stand back and look at what's going on with our health system. So this is a framework that we've been developing that understands that there's been at least 2 eras and not 3 eras of care. And we've gone through 3 major transitions. We're going through the 3rd transition now. The first era was focused on saving lives through acute care, emergency care, rescue care, and in the public health world it was around safety, protecting people through quarantine and water safety and the like. The second era was focused on prolonging life as people started to live longer. Instead of, in the first era, life expectancy was 45 years of age. As we started to hit 65 years of age, people are living much longer, and we have more chronic disease, and we focus more on prolonging life and decreasing levels of disability through disease management. And we're now entering the 3rd era, which will focus on optimizing health and well-being through primary prevention, health promotion, and community integrated delivery systems. And it looks something like this. So the first era starting in the 1850s or 1800s, I think here at Hopkins when Welch and all, the Osler and the, giants that created this place, it was all about, focus on acute care and a biomedical model. And we created biomedical institutions, and we created hospitals and clinics, and they were connected to each other because that's what the model was. And it was about short time horizons because we weren't managing disease over long time horizons at that point. And we created our medical care model. We created insurance-based financing because most of this was unexpected, and it was starting to cost a lot of money. And we developed an industrial model of production in order to reduce deaths. That's why this hospital across the street, most of the hospitals across the United States look like big factories, you know, because they're organized like big factories to produce the services that they do. And what we did is, as people lived to be 65 years, by 1950 or so, we had an increased focus on chronic disease. So the model changed. We moved the chip. You know, the new chip is the biopsychosocial chip. Because the biomedical chip doesn't explain everything and it isn't useful for all of it. And we now, over longer time horizons, because we're managing chronic diseases, and when we think about prevention, we understand there are multiple risk factors. And focus on chronic disease management, but we also changed the financing from insurance to prepaid benefits, because we know people are going to have a pap smear, a prostate exam, cholesterol check, and such. So those aren't unexpected and insurable events, but things that we pay for. And we're moving towards a corporate model of care. How many have heard about ACOs? Everybody's heard about ACOs. But ACOs are accountable care organizations. But ACOs are corporate entities that are being aggregating the cottage industry that was medicine, and aggregating all the doctors and saying, no more fee-for-service, you're going to be part of our corporation, and that's how we're going to run things. And that's what ACOs are all about. It's moving towards 2.0 care and having a better chronic disease management system. And the focus is on prolonged life. Well, we're heading towards this increasing focus on achieving optimal health, the focus on life course health development, with a lifespan and intergenerational. How many of you have worked on preconception care or learned about preconception, right? Because that's a cross-generational transfer of risk that's non-genetic oftentimes through epigenetic and other mechanisms. So we're changing our models, and we're going to be investing more in population health. We don't have the fiscal tools yet to do this, but we need to invent the fiscal tools. Just like we went from prepaid benefits, one of the ways that I think we're going to be moving is towards developing health trust and using social impact financing. There's going to be a whole set of new financing tools to make this work. And we're going to move towards a network model of health delivery, not a corporate model. So it'll be much more distributed and be using I was in the Grand Rounds this morning, the guy that was my warm-up act, was one of the medical residents, and he gave a thing about all the medical apps that are coming, or that exist. And that's where we're going to be headed. And so we've gone from this 1.0 system, 2.0, to what we're going to 3.0. Most of the American health system is about 1.5 or 1.8. Many of the inner city systems are about 1.0. They're still just basically doing rescue care. And, but most of the European systems are about 2.2 and moving towards these more population optimization. And the reason they're going to have a much easier time of it is they have a social scaffolding that's going to allow them to do that. And they are able to deal with the social determinants. And we're still fighting our way forward on it. So this is back to that model I showed you. So just showing, from the 1900s, 1950s, how we've moved through these cycles. And the science and our logic models are associated with the production models. They're not disconnected. And our major production model for society now is around information technology and is a network production model. So that's where the health system is going to be headed also. And so one important from a health policy standpoint, so if you have these two trajectories, and we know most of the actions there, you become symptomatic early, what happens is the cost curve looks different, right? That's when the costs start going up. But if you want to go in a higher trajectory, if you invested more, we see a different cost curve. And part of why this is important is that right now with our 1.0, even moving to 2.0, what the rallying cry of health reform was what? What is the rallying cry? Bend the cost curve, bend the cost curve. We're going to bend the cost curve. I think it's a fool's errand. I don't think we're going to bend the cost curve because, one, too many people making money down at this end, and too much profit being made. And I think the only way we're going to shift the cost curve is by shifting the health curve. And that's where the real action is. And that's where we need to be moving. And as we move to 3.0 care, both upstream and up the developmental spectrum, we'll have much more leverage on what we need to do. So CMMI created this model when we were working with them around what a a 3.0 system. So we moved from accountable care organizations to community integrated systems. And so the SIM initiative, the state innovation model that's out right now, Maryland's going for it, and Maryland's, I think, model is going to be around kind of a utility around community health teams. The Michigan model, the Vermont model, they're all trying to build 3.0 systems for the SIMs. So they're trying to move in this direction towards what, they can do. Fortunately, the White House pulled out of the SIM initiative all the 3.0 language. Actually, it was all in there. But there was some probably Hopkins grad that was in the White House who was 26 years old and said, oh, I never heard about this. If they had been here, it might have, gotten in. So anyways, it got pulled out. But the SIM initiative had, sort of focused on this kind of a approach. And so when we start to think about the transition, from 1.0 to 2.0, from where we're at now to where we want to get, we want to see the logic model change. So the logic, here's the old logic, here's the new logic. I don't know if any of you watch Bill Maher, that sometimes he goes, here's the old and here's the new. I was thinking about that this morning. So here's the, it's more developmentally oriented, optimizing population health. It's about the individual population and community using a life course health development. So it's a different operating system, different driver diagram, different logic model. So when we think about the organization of health services, most of our organization of health services currently is in these silos. So you have health plans that are private or self-paid, you have hospitals and specialists. They're sort of vertically organized systems that have been created. That's what we were able to do over the last many years. And all of our public health and population health is in its own silo, and it's funded differently. So your school health centers aren't funded out of the same mechanism necessarily that is going to this. A lot of them are Medicaid funded, but they're funded through a different way and a different. Mental health services are carved out. The early intervention services are paid through a whole different format. So if you want to have an integrated health system, you have to have the community and the medical care integrated. This is from the Nemours diagram for what the Nemours Health System is trying to do up the road here in Delaware in terms of trying to operationalize the Wagner care model and a population model for health. So when we started to think about if we were building a 3.0 kids ACO, how would you have an integrated finance mechanism? How could you take Medicaid and CHIP and employer-based funding and individual and prevention trust fund and Title V and others and put it into a trust in a community? And so some of that money is going to go to individuals and some of it's going to go to populations. And in fact, there's a proposal in California right now for their SIM grant to create something like that. And then how do you build a network where primary care is in the center? And I'm doing homage to Barbara Starfield here. This was her dream to put primary care in the center. So you have primary care networks and primary care resource centers like they have in Denmark and New Zealand that are shared utilities, okay? You shouldn't have every doctor having to drill its own well and generate its own electricity. So why did they have to have their own community health teams and stuff? So how do we share them? And then how do we have integrated the early intervention family resource centers, school-based health centers? How do we use our measurement IT systems to make a system work? And how do we create a value portfolio where we're measuring health trajectories and looking at population outcomes to make that work? So how do we actually design pediatric care in a different way? So here you have nurse family partnership, early Head Start, pediatric medical home, early Head Start, triple P, you get the drill. There's health, medicine, health, education, and social welfare program. And if you horizontally link them together at each part of the lifespan and longitudinally integrate them, what have I done then? I built a scaffolding around the higher health trajectory. And I built a scaffolding, I designed it, right? I built it because there should be some codes, building codes, just like this building. Well, this building might, the building codes are probably pretty old, but most buildings are built with building codes so that they don't fall over in earthquakes or storms or other kinds of things, right? We build them that way. Well, we have lots of children in the United States living in communities that have earthquakes rolling through their lives on a daily basis. Yet we're not building our systems with the kind of building codes that will sustain their trajectories. They just keep getting knocked down to this lower trajectory. So this is using life course theory to inform design of systems that actually will be structured to support the human development or health development. So how does the pediatric office have to change? Well, 1.0, the office was just connected to the hospital. 2.0, they're connected to the specialists, right? 3.0, you have preventive and developmental service care, and it has to be connected to all this stuff, like what Healthy Steps was trying to do. So you need to be able to have all this connectivity. We have massive amount of connectivity in our lives in other ways. We just haven't brought it into the health system. And if we're going to change that, how do we change the 2.0 medical model in the pediatric office, where we're screening kids for developmental disabilities, and it's still just the 4 to 6% of kids that we're going to send into the IDH system, which we do a crappy job of anyway, right? You know, my state, California, I think it's 1.5% of kids make it into the IDH system. In Vermont, I think it's about 6% or 7%. I think North Carolina is about 5 or 6%. It should be about that number, because those are the number of kids that should be, epidemiologically should be eligible. We just have systems that don't work. But we have a pediatric office that's only connected to the regional center, and it's not connected to the services need. And if we're going to do 3.0 care that's about not just looking for disability, but it's about optimizing health, what do we do with the 30 to 40% of children that have behavioral mental health and disabilities that are going to be picked up by the school, but by the time they're dealt with in school, the kids will be 8, and the parents know that they have a problem at age 3 or 4, and the pediatricians are looking away because they can't deal with it. So I didn't have the slide. In Orange County, California, they put in a system to try to deal with it. Let me get to the end here so I actually get to the end. Performance monitoring. So HIT in the 1.0 system is about diagnosis and treatment. It's about electronic health records that connect the hospital and the ER, so you know that when the guy comes in with a big scar on the abdomen in the ER, you know that he had his abdomen open because he lost his spleen or whatever. You know, so you have these sort of basic information, and you increase medication errors and the like. Chronic disease management or decision support systems that are being built into the EHR systems and learning systems, like most of what PCORI is trying to do. PCORI is trying to build those kinds of systems, and the learning health system efforts that the IOM is doing. And there's a group of pediatric investigators that Chris Forrest and Peter Margolis are leading about building a learning health system around for pediatric care that's going to be centered at CHOP and Cincinnati Children's. There's about 6 children's hospitals working on it. But that's mostly that. But 3.0 is going to be about population health measurement, optimizing the health of the population. So I'm going to just talk about this for the end, just talk about early childhood as how we optimize early childhood care. And so we have pervasive and persuasive information about brain development and about the economics of investing early in life. This is the Heckman curve. But we know that every system is perfectly designed to get the results it gets, and we need new levels of performance. When we go out and look at the early childhood system, we have all these different programs out there to improve brain development and make kids better, but they're not connected at all. And what we've learned from studying this over time, it's not about the services or programs, it's about the systems. We have to embrace the complexity that exists. And actually, communities are complex growing ecologies. We need to work at scale and not keep doing model programs and little model intervention. And have to understand that complex systems learn their way forward, that a learning system can turn data into information. So you have to figure out what's the learning system. And all quality improvement in healthcare is about creating learning systems in hospitals and health systems so that they can learn rapidly and change, right? So if we look at, and this is just a model that we've developed, if you look at any community, you have hundreds of providers out there, doctors, nurses, Head Starts, various things that are out there. And we're trying to get it to produce healthy development. At the community level, you have all these community-based organizations that are providing services. In the county or city level, you have the departments. They're linked by funding streams and to make them do what they want to do. But this is one big whirling vortex. It's like a weather pattern, right? And it just whirls around. It's a little bit like a pinball machine. And if a kid gets their services, it's because they happen to bounce off the right things more than any sort of deliberate design. And you have lots of chaos in the system. So part of what we're trying to achieve is how do you align this Department of Social Services, Health Services, Child and Family Services so they're actually working together towards the same goal? How do you get the communities to work as a network in a network provider standpoint so that they're networking their services and learning from each other? So that you get user interface, a pathway that actually works for people. Right now, the systems are designed to be user-friendly, and they're not. And so how do we move in this direction? Well, one way you do that is you create a learning system so that you can learn from each other and make it work. So when you go into communities, you have all these different services, so how do you align them? How do you get the sectors to align? What tools do you use to get the sectors to align? Well, one, you have to have a common agenda and a way of communicating. What we've been using is optimizing health trajectories or developmental trajectories, because the schools get it, child welfare gets it, they all get it. So you have to have some kind of common framework. You can't walk in with a medical home or, it doesn't work. You have to have something that's a common agenda, and you have to be able to communicate it. You have to have a shared outcome because everybody has to be managing towards the same outcome. And we're using school readiness, but you need to have a data system. You have to have some kind of collaborative systems improvement. So what we've learned from IHI, what Toyota's learned, what all the companies have learned, use a common system across all your departments and stuff, and you see change happen. So you have to use the same systems change framework in the health sector, child welfare. All of them have to be doing this and working together. And you have to have financial policy alignment. So what we've been doing is trying to say, okay, if we're interested in measuring and achieving better health trajectories, we should actually be measuring health trajectories, right? If we want better outcomes, let's measure school readiness, because school readiness is the health-related quality of life of a 5-year-old. Now let's get off of the MCH old, which is measuring infant mortality and other things. Enough already with infant mortality. I mean, we're not where we need to be, but it shouldn't be the only thing that we stand for, right? And, there are other health outcomes, not just measuring how many babies die. And so we've been using something called the EDI. And the EDI is an instrument that measures 104 items, and it takes about 10 minutes for kindergarten teachers to do. We do it on all the children in the school at kindergarten. And it measures social competence, emotional maturity, language, communication, physical health, and well-being. So you have a holistic measure of how a child is doing. And this is what I saw initially 10 years ago. Clyde Hertzman was at a meeting that I had, that we had in LA. Frank Overclade and I and Larry Eber hosted a meeting about 12 years ago, 10 years ago in Los Angeles. And we brought teams from Australia, Canada, the U.S. There were people from the MCH Bureau. David Heppel was there from MCHB, who actually funded the meeting that we did to do this. I just want Peter to know that his money went to good use at that time. And Clyde walked in. Well, each one of us sort of said, well, what are we doing around early childhood? We laid out our policies and our plans, and we shared our tools, and they put this up. And what this was a measure of Vancouver and BC, and they were looking neighborhood by neighborhood, and they could tell you the vulnerability of children neighborhood by neighborhood in terms of their social competence, their emotional maturity, and various other things. And when I saw this, I thought it was like seeing an iPhone for the first time. I just thought, oh, that's a game changer. And what they told us was the difference in terms of having something like this, the real importance was, is you brought data down to a neighborhood level. When you bring data down to a neighborhood level, it's the difference between being able to say that 50 kids died in Baltimore last year in car accidents. And all of us go, oh, that's too bad. And that's a statistic with a tier. We don't do anything different. We all get in our cars and drive the same way. But if you know out on the corner of whatever the streets are out here, on that corner, the 2 kids died there in the last 6 months,
something's going to happen to put speed bumps. The neighborhood comes together because it's something that means something to people about where they live and how they identify. So we started doing this in Orange County, California. We're using Green Map, and this is looking at the levels of vulnerability. And so we can look neighborhood by neighborhood at vulnerability rates, and we can map poverty to that. So what here, you see that's high poverty and high vulnerability and two or more of the indicators. So you have two or more areas where kids are vulnerable. You can sort of see where they're vulnerable. Interestingly, up there's low poverty and very high vulnerability. So why is that happening? Well, what's really interesting is all the off-diagonal stuff where you see high, low, or low, high, and you don't understand why that's happening. It turns out there was a housing project there, but it also turned out, I don't know if I don't know, it also turned out that it had no early childhood services, there were no healthcare clinics, there were all kinds of things that were wrong in that area. So the people, and it was also a very transitory area, so there were middle-class people that were moving in and out, there was no social capital. So we've been doing something called the TEX initiative, which is our version of doing 3.0 healthcare, 3.0 care. So we're trying to align community systems, improve trajectories, measure and map what we're doing. So we're engaging communities, measuring and mapping what's going on, targeting systems improvement in those communities, and have a shared learning system that we're using across the communities. And we started with 8 places in 2009, and went to 18 the next year, 30 the next year. We had 50 this last year. And as you can see, there are a bunch in LA where we are, but gosh, look at that. This was completely unpredicted. Big uptake in Texas, Louisiana, Mississippi. We would have never predicted that. I thought it was going to be in Michigan and Maryland and the progressive states. Well, the part of what we've seen is that there's quite a bit of interest in these states, and they're all using these maps for different things. They're using it for school readiness, they're using it for community initiative. We're using it in Texas for the MCHB home visitation programs. In fact, that's our partner in Texas. And so they're using this as their measure of community outcomes for the school readiness, for their home visitation. And I'm going to finish with this last, which is the Magnolia Community Initiative, which is going on in LA. And what we're doing at Magnolia, this is where we're trying to use these life course principles and 3.0 sort of constructs to sort of, how do we improve and help 35,000 children in this part of LA, this 5 square mile, how do we help them all thrive? We could have gone into Magnolia and built a super duper child education, child development center that took care of 300 kids or 400 or maybe 1,000 kids if we were lucky. But we decided that, well, I didn't decide, they decided that it was going to be a system that would serve 35,000. So they wanted to work at scale. So there's 6 hubs in this area. I should just say that for those of you who know LA, that's the 10 and the 110 freeway and the 10, that's where the Staples Center is. This is where USC is, a very poor area in the central part of Los Angeles. And there's a whole model about how it's organized. But there's 6 hubs, there's 71 partner organizations, there's 100 community groups, there's 500 block advocates that are being developed that serve the 14,000 families. These are people coming together from the different community-based organizations, the clinics, the WIC sites, the religious organizations. For those of you who have done quality improvement, these are the storyboards that are up there. I don't know how many of you have done this, but the storyboards are sort of laying out what you're trying to achieve, what your metrics are, what you're working on. They're all using IHI type of quality improvement, but we're doing it not at a clinic or hospital, or we're doing it at a community-wide level. How do we change? How do we move the dot in the neighborhood? We have a driver diagram. What you have here is a percent of kids that graduate from high school. These are the 10%, less than 10% of children that are developmentally vulnerable on the EDI. So that's one of our, 3rd grade reading, and we're starting to link with the campaign for grade level reading, this initiative, with a whole set of immediate outcomes. And these are the things we're managing on a daily basis. We're trying to get to a bit. And so that's the 10% annual increase in percent of sharing books, 90% of mothers report positive relationship with their children. These are the things that we're trying to move on a daily basis. The EDI scores aren't going to change rapidly. They're going to change over 5 or 8 year period. The school graduation rates are going to probably be even longer. But you need to have a logic model, a set of drivers that you can understand. And these are the practice drivers that each of the communities, organizations are working on. Things that about how do they support parents better, how do they demonstrate more empathy, how do parents report that they're having their developmental concerns addressed, how are they working across sectors, how are they being more efficient. Here are the culture and leadership drivers. So these are the things where we're doing improvement processes and doing PDSAs where we're testing things, plan, do, study, act cycles where we're going through and testing things. And there's the maps for Magnolia. So we're measuring, this is social or communication ability, and this is parents reading to their children. Dark green is much higher vulnerability, and the reading rates and such. So we're trying to map this stuff. I don't have the social competence and maternal depression. And I dare say you can't go many places in the United States where you can walk into a neighborhood and you get to say, well, in this neighborhood, the social competence of the children, vulnerability is this, and this is the percentage of mothers in this neighborhood that are depressed. You can make some guesses about it, but we're actually doing it, measuring. And what it does is it brings people together to have a very different conversation, because you can sort of have the preschools, the mental health people, the early intervention, the health people, social welfare, the police department, everybody else wants to be there to have the conversation now about what's going on in that neighborhood. We're doing parent surveys, we're developing run charts, and we have dashboards, and we're taking collective action to have collective impact. This is sort of like a different model from the Harlem Children's Zone. Right? The Harlem Children's Zone is kind of a quarterbacking model with the Jeffrey Canada football team moving forward, and it's kind of corporate organized. This is a lot more like a soccer team or a pickup soccer team where you have lots of people from different organizations coming together and working together and learning from each other. Simple rules in soccer. Everybody has their positions, but everybody moves together. No one's calling the plays. Right? And so we're sharing the data for action with residents. And I don't have the picture of the dashboard. We have these wonderful dashboards, and what we see on the dashboards and where we're making change. And what's really humbling is things like where you can't get any movement on things, even though you're using evidence-based approaches, like getting parents to read to their kids, and you're doing reach out and read this and that and the other. It's supposed to be working, but it's not. And you're running cycle after cycle. Why can't we get this to work? Okay. But other things that we're finding work great. So we've got our surveys and we've got run charts that show that no matter whether the parent comes through a WIC site, child care clinic, a preschool, wherever it is, someone's asking them about, do you have any developmental concerns about your child? And if you do, can I make a referral for it? And what that means is we've been successful in creating a no wrong door, single point of entry into a network of providers. So what this is about, back to this model from 3.0 standpoint, we want to manage populations. We have a community health center in there. We have several community health centers there. They're all practicing 1.8 medicine. They want to be 3.0. They're dreaming 3.0, but they're still 1.8, so they have to re-engineer themselves. But here we have an outside-in strategy, right? We have a community now that has a scaffolding of data of improvement process. So if you're a community health center in that neighborhood, there are community health teams or community teams working on improving how children are doing. So if you want to launch something from your health center, there's someone to catch what you're launching. You're connecting to things. You're not having to build all the infrastructure yourself, which is usually the case and is a prescription for disaster, because the community health center can only build scaffolding out so far, and if there's nothing to connect to, it doesn't work. So back to this model, my complex systems model, right? Multi-level complex systems. In order to get the policies and procedures aligned, we've got an overarching initiative. We have an integrated network that's helping us learn at all three levels and feeding back to all three levels. We have maps and analytics that provide currency, and we have this system of learning that's allowing us to build pathways that actually work for people. And I show this just to show that it's possible to think about, taking ideas. It's not all about ideas and frameworks, but actually taking those ideas and realizing them in real ways by innovating and adapting them to situations and figuring out how you're going to do things. So, conclude, we need big, bold changes for our child health system. By 2025, we need to really be transforming our child health system. And we're not going to do it by all of us individually working on things. We have to have collective impact. What you're doing at Hopkins and what we're doing at UCLA and what they're doing communities around the country all has to be linked in some way. And we have to adopt a 3.0 strategic framework for research and systems transformation. We have to believe that children can lead the way in transforming our health system. It's not going to happen with the frail elderly adults with 3 diagnoses and various other things. We have to make the unnecessary catastrophic loss of health potential an unavoidable and inconvenient truth for our nations that our leaders cannot avoid and can't run away from. And we need a child health futures network that is going to move us forward to do the kind of innovation and change like what we're doing in Magnolia, what Bellin Healthcare is doing in Milwaukee, what Southeast Foundation is doing in Anchorage, what I'm sure is going on here in Maryland. But we have to be linking up because the innovators and changers have to come together. Because the 3.0 stuff is there. It's the Gibson quote from the writer from the mid-90s that said, the future's here, it's not evenly distributed. And a lot of this 3.0 thinking and models are there, it's just bits and pieces. It's all there, we just have to start assembling it in certain areas and see that we can make it work. And we have this life course research network that has a lot of life course stuff. I talked about in the pediatrics audience, we have something called the Child Health System Transformation Initiative that I'm working on, along with Debbie Chang and Lisa Simpson from Academy Health, and there's a whole bunch of other people working on it. Tina Chang here is working with us on several of the initiatives. Carol has been working with us and actually helped us a lot in the meeting that we had in June. So we have this group of people that are coming from across the country that are interested in transforming the health system and are interested in changing how children's hospitals are going to work, changing the way that FQHCs. I didn't talk about it here, but we're going to see 10 or 20 of the children's hospitals go out of business in the next 10 years because they're just not going to survive the change. So how are they going to transform themselves into 3.0 centers of integrated networks? But we need to be working on this stuff together and moving forward because there's huge disruption happening in the health system right now because of the ACA. And we have new ideas and new science and new tools and new designs. And we're going to fail miserably if we're not applying them in a real way. It's important to continue to do research, on life course issues and fill in the gaps, but we know enough right now to actually make big changes, and we just have to muster the wherewithal to do it and work in different ways than we have. So let me stop here, and thank you for your time and attention. If there are any questions that people have, or challenges that want to tell me I'm full of it. Yes, ma'am.
Is there a 4.0 or a 5.0?
Well, I don't know.
Where's 3.0 to end?
Yeah, well, it's hard to sort of see over the next horizon. I'm not sure. I'm not sure what 4.0
Sounds like
is. Yeah. But I think we have to be thinking that way. Yeah, It was interesting when I went in and met with the head of CMMI, the head of CMMI, and I said, well, all his population health people wanted to move towards this 3.0 and wanted them to adopt it. And he says, I'm only going to 2.0. He says, that's my job, get us to 2.0. And his staff just looked at him, but that's all we wanted to do. So I think we have to link vision with our understanding and the know-how of doing things and actually start prototyping, and experimenting. And we can only do this together. What I've learned from doing quality improvement work, when you have really tough problems and there's one person working on it, they get it about 20% of the time or less. If you have a team working on it, you get it about 30% of the time. If you have a network working on it, you get it about 100% of the time. So we need a network of places working on this to move this forward. And we have, the problem is we've all been taught to work individually on these tough problems, and we're not making much progress. And, we're trying to work in teams more, but we really have to form networks. We have the ability to do that. We need to be figuring that. And places like ARC and MCHD and stuff need to sort of realize it's a new day and need to be funding things differently.
Just need to tell our Congress people to direct them in the right direction. Great. Well, and we,
Were you going to ask a question? No.
one last question.
So thank you so much for the presentation, and just I wanted to ask, I was fascinated with the whole experience. So to get those multiple organizations and people who are doing at the community level, you must have faced some challenges to make them all share one vision.
Yeah.
So,
But it's been challenging, but there's been great leadership, but it's been very understated leadership. It's not one place trying to link it, so the backbone functions isn't one organization, but it's distributed. And the learning system's really been important because people have been able to watch what they're doing and see what they're doing and see change happen. They're not seeing, it's not dramatic change, but there's, they're working in organizations and health centers and websites and, where nothing changes. They're just dealing with year in and year out with the same old problem. I mean, the same thing, people say, well, how are you getting schools to do the EDI, right? When they're having to, be accountable for all these educational outcomes and blah, blah, blah. How do you get them to do it? How do you get school teachers to do it? Well, you start talking to school teachers, you don't say, well, this is just another accountability measure that you're going to have to answer to Arnie Duncan for, whatever it's called, not this is, but the other education law. And, but you say, this is something that we're using to sort of transform the community. And then you have teachers say, after they've done it, they say, you know what, I've been at this school for the last 8 years teaching kindergarten. I've been about to quit because every year half the kids walk in the classroom and they're not ready to be here. And I spend the whole year working trying to get them caught up. And at the end of the year, I get about half of them caught up, but I still have a quarter of the kids that I don't feel good even sending out. It's the same thing for pediatricians. They take care of kids every day in their clinic, and they look away from the problems facing them because they can't deal with them. And so when you sort of say, hey, we're going to do this EDI, and we're going to measure and map it, and what the school teacher says is she says, you know what, I'm doing this because for the first time I feel like I'm stepping off the curb into the community and I'm working upstream and maybe I'm introducing some hope of the next group of kids, maybe not next year, but a few years down the line. So it's not going to be half the kids, maybe we'll do better. So you're trying to appeal to people's higher aspirations and pull them together, but you're giving them feedback so that they can actually see what's happening. And I think that it goes a long way. I learned from doing quality improvement work that does work. People will stay with you on quality improvement if you're sort of getting feedback and you're actually learning. If Cynthia's the health person, and I'm the education person, Camilla's the social welfare person. We're coming together and we sort of say, we're all managing towards this outcome. We're going to work on something together. Let's say it's around doing better developmental screening. And, Cynthia's been wanting to do that better for years, right? And so she's committed to doing it. But she's got to convince everybody in her clinic to do it better. We help her, we give her, she gets the right tools and stuff. Camilla's at the WIC site, you know, and she's now going to be teaching moms that why a developmental screening is important and why you need to do it. And I'm the preschool place, and I'm going to ask for the developmental screening. So what we've done is we've now aligned things so that as Cindy's doing the change, she's getting reinforcement because there's someone demanding it on the parent side and schools demand. So we've created cross-sector integration and flow of information, so it's being validated. So we're creating a new value stream. So we need to be thinking about how we do this stuff so that we're able to, you know, move it